Okay, hello everybody. We are now going to reconvene with our second panel. And I am excited to present Shira and Holly. I'll also be there, but those two are going to be doing a lot of heavy lifting today on the second panel. We're going to be talking about health plan trends, and we're going to start off with Shira, but actually maybe Shira and Holly, you guys could introduce yourselves before we start. So thank you.
Sure. Hi everyone, nice to meet you. Can people hear me? Okay, good. I saw nods in the back. My name is Shira Hauschen. It's very nice to meet you. I'm managing principal of Dorsey Health Strategies, which is Dorsey's healthcare consulting group. We're a group of folks that are focused on the business side of how to actually make things go. A couple of us, including myself, are technically licensed attorneys, so I'm aware of and very much appreciate the legal issues, and I'll actually call out to them a little bit in my talk today. But mostly the sorts of things we think about are very much how to actually operationalize and make something successful from the business side. So I'll be talking today about telemedicine. The quick other thing I'll mention by way of background is the reason I was really excited about today's panel is because I've been in the digital health arena for quite some time. I started out at Epic, so thinking about EHRs and what you can do with data and how employers and other companies can leverage data has been really interesting to me. And then I was at McKinsey, so that was business consulting, focusing on healthcare IT. And then I was director of operations at a telemedicine company. So my perspective today, as I share with you, will be very much from the side of the telemedicine vendor, from the provider side. I have actually been more in your shoes, evaluating it as a purchaser as well, but hopefully it'll be helpful for you to see the other perspective.
And good morning, everybody. My name is Holly Fistler. I'm a senior attorney in the Benefits and Compensation Group here at Dorsey. I've been practicing in the health and welfare field as well as the retirement field now for about 10 years.
Good. So why don't we start off? Shira is going to talk to you today about telemedicine. We think that that's one of the trends that people are really looking at and really interested in. And so we're going to lead off with the big topic of telemedicine.
All right, let's see. Is that right?
Oh, that's Andrew.
Backwards.
There we go.
Forwards, always forwards. So let me give you a couple of quick caveats and notes about what we'll be talking about, at least just during my portion on telemedicine. And first I'll say, so I teach a course in which 2 4-hour sessions are on telemedicine. So today in 20 minutes, consider this the barest overview. But really, if you have any questions, don't hesitate to reach out. I'm happy to just off the clock talk with you about the things. And I have my email at the end of this, and you can find me through the Dorsey website. So this will be very, very high level overview. Second is, I will say, although I'll cover some of the issues that you think about kind of even from the legal perspective or business at high level, I will say our group, the Dorsey Health Strategies Business Consulting, we think a lot about, as I mentioned, how to operationalize, how to actually put it in motion. And I would really encourage you to do the same if you're not already. Because I think what ends up happening is that employers get excited about a specific telemedicine option, say, great, let's go, and the follow-through, because there's nobody on site to actually carry the baton at that point, doesn't happen. And that is what leads to some of the low utilization rates that you may have read about or maybe even experienced. So I'll put that as a recurring theme that you'll hear. Last but not least, I will say it is my fault that we added in telemedicine as a trend in terms of the name, but I would actually argue it's not really so much a trend as something that is a tidal wave that's been happening here and now. You probably know there was a survey widely publicized a couple years ago that said that 71% of large employers with 500 employees or over were already offering a telemedicine option. And then last year, the National Business Group on Health found that 96% of employers, period, of all sizes, wanted to offer a telemedicine option. That was last year. So my hunch is that most of you in the audience are already offering or thinking about offering it. So please don't think of this as a trend as in it is coming, but more as in it's here, what do we do about it? So I'll give that big caveat. So what do we mean when we say telemedicine? And I actually thought it might be good to level set not only on telemedicine, but on digital health. Why? Because probably all the people that you're talking to as potential partners, or maybe as your current partners, are throwing these terms around, and they have different meanings. And so anytime anybody says to me, hey, we're thinking about offering telemedicine an option, I say, okay, what do you mean? What do you actually want to offer? Who are you talking to? So if you think about the blue box as I'll just stand, as the digital health universe, this actually encompasses...
I have to hear you, though.
Oh, and they can't hear me.
Sorry.
My apologies. The blue is the digital health universe. So within that, and I put in green because it is what we're talking about today, telemedicine is one subset. And virtual care, telemedicine, and telehealth tend to be used synonymously and interchangeably. Telehealth is actually not a perfect synonym because it's a little bit broader than telemedicine and encompasses things like, for example, wellness and other things that we think about as health. But in general, most people aren't so precise. So when we're talking about telemedicine, that is one subcategory within digital health. And you may encounter digital health vendors that in fact are telemedicine vendors. So I wanted to make sure that we called out all the different terms that you might encounter so that if you saw a digital health vendor, you didn't dismiss it and think, okay, wait, that's not what I want, because it very well could be what you want. Another subcategory is asynchronous telemedicine, which is remote and store. This actually, it's funny, it's the oldest form, and this is the idea, for example, a scan going, radiology was the first example of this. Going to somewhere else and then remotely a clinician is reviewing something. Doesn't have to be a scan, could be lab results, could be a wide variety of things, device data, and then it's separated in time, hence the asynchronous, and then reviewing those and then giving results back, whether in the form of a virtual visit or in some other data transmission, for example, to the electronic medical record. So that is also still a subset of digital health. It is sometimes, by the way, also still called telemedicine, which is again why I say, what do you mean? Is it virtual and real time? Is it asynchronous? What's actually happening? A third category is remote patient monitoring, usually shortened to just be RPM. And that's where data from devices and wearables, both of those categories are really big. The patient is being monitored in one way or another, at home, at the hospital, at work, frankly. And then the data can actually prompt a virtual care visit, or it can prompt other sorts of things. So this is actually a pretty hot category lately. I suspect that employers are increasingly going to be seeing more of this, even though most people are currently focused on telemedicine. The last one is included and doesn't have a great name, but it's around data and using data in ways that inform health. I actually would like to see employers do more in this realm. I know that there have been conversations I've seen and heard about around how can you best leverage all the big data that's out there. That, by the way, is not just the data on your employees, but it's publicly available data that different really smart analytics companies look at and say, actually, you know what, you can find out some really interesting things about the health of your population based on different habits that you wouldn't have necessarily known about. And also places are leveraging their own data, licensing it, and actually monetizing it. So there's a lot that's happening in the data and the analytics realm. Last but not least, not up there, but I should note, hybrid models are probably the most prevalent, or at least rising currently. And by that I mean that we did a survey, I just presented on this yesterday, of 20 of some of the largest hospital systems in the US. This is hospitals, granted. But we said, okay, what are the actual telemedicine offerings that they're doing? And all but one are offering some sort of hybrid model. An example of a hybrid model would be, for example, perhaps you have a remote patient monitoring setup. I'll give you an easy one. Wound care. Somebody has surgery and there's a smart wrapping and it monitors the state of the skin and of the healing, or maybe whether or not the patient is doing the required rehab. The data from that could then trigger, if the patient's not moving correctly or other things, it could trigger a warning, and an actual virtual visit would be scheduled automatically. Or it could, so that would be remote patient monitoring plus virtual care, plus the data could be sent to the interested parties as well. So there's been some really interesting combinations that have been happening. From the employer perspective, the models that I hear about the most would be kiosks on site that employees can go to and then have a visit right away. The other would be on demand, and by that I mean logging into a website or an app. Think of things like Teledoc, Doctors on Demand, Virtuelle, where I was, Zipnosis here in town, and that could be done in the privacy of an office or some other place. It could be done technically out on the street or at home. That's been increasingly on the rise, and actually it's been really interesting to see what some of the different vendors are doing that are out there. This is something I'd love to talk more about. Second opinion services have started to become really popular. Some of you folks may be offering this already. So the ability for any of your employees to, if they've received a verdict from one doctor, to be able to call up, and these are usually aggregated, almost like really staffing services in a way, to be able to call up specialists and get a second opinion. And last but not least, and probably most on the rise, is telemedicine in specific specialties. The most common one that I've heard employers talking about is telepsychiatry. So your employees being able to call up and do group visits or individual counseling visits. And in general, by the way, in telemedicine, that's the fastest growing specialty. So those are the ones within telemedicine. So all of this is to say is, if you are talking about telemedicine either within your company or to potential vendors or partners, always, and this is not only from a business but from a legal aspect, ask really specifically, what exactly are you talking about? What is the employee patient accessing through what medium and in what state? We'll get to the state things a little bit, but the state matters greatly in terms of telemedicine regulation. Last but not least, I'll only gesture because I don't think I have to sell you on the benefits of telemedicine because you wouldn't necessarily be in this panel if you weren't already thinking about it. But in general, the reason that telemedicine is so prevalent, and not just a trend, but here and now, is because of all the benefits it offers. So for the patient, it's care untethered. You don't have to leave your workplace. You don't have to go and wait in a doctor office. You don't even necessarily have to call and wait for 4 weeks out to get seen for something that you think is strep or a bad cold. Instead, you can access the doctor, whether it's on the app or whether it's through the kiosk, whatever it is that you, the employers, decide to offer. And also, by its nature, given the business model, they're able to staff this in a way that they can have a call center of doctors, or frankly, a lot of times, and this is what I saw at Virtual and also Hypnosis, doctors and nurse practitioners are working from home. This is hugely attractive to providers. So the point is that your employees can be seen much faster, which results in a healthier workplace. So for employers, it's reduced absenteeism, it's a healthier workplace, especially for things that could be quick and easy and not require an urgent care visit. And then also reducing the cost of benefits. This is a really big one. Lastly, for payers, this is really an attractive option as far as reducing the overall cost of care and the data that comes out of it. I actually work with a wide variety of health industry segment companies, and that includes payers. And I think that not just payers, but everybody's sort of scrambling to say, okay, what can we do with all this interesting data? Because we can find out and think of ways to help other populations as well. So moving forward, what this does is it changes the landscape quite a bit. It was actually in the news maybe day before last, I think, in Becker's, that multiple, I think it was 30% was cited of executives said that telemedicine is the biggest disruptor in healthcare. I absolutely agree with that, because if you think about it, now for any sort of provider of care, instead of actually building hospitals, so you go from real estate and leasing, now you're talking about IT and licensing. The barrier to entry is much lower. It's a totally different landscape. And so instead of you thinking about providers in the traditional clinical and hospital and other sort of care setting, now you're talking about totally different companies. So that's why I actually put this image up on screen. Before, you would have patients. That dotted line in the middle there would have been a solid line. Patients would interact with the provider. There's interaction with payers over there. And then software companies, medical device companies and such, they interacted across with payers and with providers, right? You wouldn't necessarily have the patient necessarily interacting with them just one-off. That's different now. Now, the software companies who are getting into the healthcare space, you have telemedicine providers, which didn't even exist before. You have retail. Think about Best Buy and their acquisition of the Untitled devices. You have medical device companies that are offering medical devices tethered to services. So now, instead of selling to hospitals, they are selling directly to the patients. So it totally changes the game. Instead of having arrows across, you've got the patients interacting with everybody. What does that do? That eats into the market share and changes the competition for all the providers. For employers, that means you have way more options to offer the patients. So it's a scary world for providers, and I actually work with providers on this in the sense of you need to actually be offering this or your market share is going to decrease. But for the patients and for employers, it's an exciting time because you can offer a wide variety of different options. So we are a law firm, so I thought I would gesture to the legal things that arise. We could spend an entire hour talking about any one of these. I won't do that to you. I wanted to at least provide a list. If you have any questions about this, please don't hesitate to reach out to me, to either Liz or to Holly, or even to other folks in our healthcare group. We'll direct you to the right person. But these are issues that we deal with all the time when we talk about telemedicine. So as you look down this list of privacy concerns, which I know Holly will be getting to, licensure, reimbursement, credentialing and privileging, CPOM, corporate practice of medicine, fraud and abuse, prescribing is a big one, FDA, contract issues, and then the really big one is state-specific issues. I do want to note that these are things that usually the offerors of the telemedicine option are most concerned about, but I decided to keep it in anyway for this talk because I think that the smart employers are going to be vetting your partners, the vendors, to see how well versed and how well prepared they are for this. I say this because telemedicine is still new enough, and there are so many companies that are rushing into this space that have not been in healthcare before, that it is not uncommon for places to close because they get into trouble on the regulation side. I can think of 3 that I know of offhand that have made mistakes, and they've been amazing telemedicine companies, one locally. But they did not have their ducks in a row. And to be clear, some of these are really tricky. The ones that I run into the most often are licensure is huge because there are different rules for every state, and the patient must be seeing a provider who is licensed in that state. So that presents really interesting, challenging staffing issues in the sense of you could be accessing, let's say that your employee is at a kiosk and talking to a provider. The provider could be in New Hampshire or California, provided they have the license for that state. I will say right off the bat that there are plenty of vendors who are not staying on top of that and making sure that their providers have all those licenses. So that's why I say when you're looking at potential partners, I would actually run through this list with them with counsel and see how they're handling it. These are the sorts of questions that I ask. I will also say that entire list is in addition to the regular sorts of rules that you will face anyway as far as plan sponsors. And I know that Holly is going to be speaking to some of those, so I didn't want to duplicate her list. But it's a regulatorily challenging world because regulations have not quite caught up to the market. That being said, there's actually been some really incredible developments this year. The VA in the government is the most out ahead as far as providers of telemedicine. And so there's more and more reimbursement. Probably helpful for you folks to know is especially in chronic care, in addiction medicine, the Opioid Crisis Response Act actually had a whole section devoted to there will be better reimbursement for helping with pain management and opioid-related therapy, narcotic replacement therapy. So that's a really exciting development. So I would be remiss in my world to talk only about the legal challenges. I thought it might be helpful to talk a little bit about some of the business things that you as employers might want to think about if you haven't already, if you're going to be offering a telemedicine option. And then I'll wrap up. So from the business perspective, please, please, please make sure that when you're talking about telemedicine, that you actually incorporate it in with your regular strategy around benefits. And I say that because I think there's too much of a tendency to be focused on telemedicine as, oh, it's this tech offering. It just somehow feels different. I would actually remind you to go back and think about telemedicine is actually just offering healthcare, just via different means. And so think about it within the whole spectrum of everything you're offering. And I say that because that'll help you also zero in on what are your goals? What is it that you want for your employees as far as outcome? Is there a specific condition that you're trying to focus on? Is this something that is, and I say this with all due respect as a potential goal, is it more about brand and image? Is it for specific outcomes, reducing absenteeism? I ask people to prioritize those goals whenever I work with clients because it'll affect which vendors you choose. It would make a big difference as to whether you decided to go with a telepsychiatry option versus a kiosk option versus an on-demand option. What is your population? What are their health issues? What is their age, et cetera? These would influence your choices. Last but not least, utilization. I mentioned that earlier. So there was a widely publicized survey that was done by Mercer, I think a couple of years ago. I've seen it in the news a fair amount with respect to employers. And it cited that, hey, everybody is so excited, the numbers I mentioned earlier, so excited about offering telemedicine as an option, but look, there's only 7% utilization. 2 notes on that. The first is the data is a little bit old. Actually, they acknowledge that as well. It's from 2016, before everything really caught on. So that has already I would bet money on changed as far as utilization. But second, I do think that utilization is a problem because of the tendency to add it as a benefit, whether it's a carrier embedded option or whether it's through the partner. But you add it in and maybe it's listed amongst the gamut of options that you have and then people kind of forget about it. You have to do a fair amount of education, and this is where involving HR from the beginning and doing things like planning for re-education of employees of this option. And I would throw out there, if we want to really get down to brass tacks, think about it for flu and cold season, especially. That's the best entryway to use telemedicine as an option. And once people use it once, the studies show they do tend to use it again. So you get really good utilization from the people that use it. So you just have to get people using it one time. I think utilization is probably the biggest challenge for employers today, and that's where it's really helpful to kind of talk about, okay, how are we going to market this? How are we going to educate this? And those are the sorts of things I deal with every day.
Shira, I have a question about that.
yeah.
As an employer, what kinds of things have you seen in terms of communication and education for employees that have been really successful? Is it sending emails? Is it mailings?
Yeah, no, that's a great question. You'll hate the answer because it's very lawyerly, but it depends. It depends a little bit. It depends a little bit on, as far as what's most successful. It depends on, I say that because it depends on your population. I will say there are some general rules that I have seen be successful. And the first is you have to assume that you have to duplicate the information, ideally 5 times. Studies show that it takes people 5 times. Think about ourselves. We get emails and it reminds us of something and you need to see it again. You kind of know it and you forget it. But if you can get to people 5 times with the information, that's ideal. Second, use more than one mode because some people will read an email, some people will notice it on a website, some people respond to mailings at home. Third, I would say lower that barrier to first-time use because of what I mentioned of it's hard to get people to use it for the first time. And by the way, the reasons for that is people aren't necessarily sure what it looks like. They don't know if it's convenient. Are they really seeing a doctor? How will, will it actually be covered? There's a lot of kind of disbelief that something that easy would be covered. So if you can figure out ways to offer it in a way that whether the first visit is wholly free, whether you incorporate it into some fare of offerings, whether just have it, lowering that first visit barrier, that's really the key as far as that.
Thank you.
So I don't want to eat into my colleagues' time, so I'll just put it on the screen really quickly and note that so digital health is something I think about probably too much, and so some of the trends that I've been watching and that really are trends and that are kind of a bit more on the horizon are personalized medicine and genomics. Really exciting. Been working with a number of healthcare software companies that offer things in this, and this, by the way, is going to be really interesting for employers. I would say in just a couple of years is probably what's coming next down the line. You can expect, I already mentioned the specialties are really hot in telemedicine, telepsychiatry in particular, and things related to chronic care. Wellness-related offerings, I failed to mention earlier, there's a huge overlap between wellness and telemedicine because so many of the wellness-related offerings are online and digital. I know Holly will be covering that further, so I didn't want to eat into her time. I mentioned big data already, and then one is exciting for the population in general is that reimbursement has been hugely catching up. Happy to talk about any of these or anything I've covered at some other time, but wanted to turn the mic over. Thank you.
Thank you, Shira. Well, and playing off of and building off of Shira's discussion about the different legal compliance aspects of it, once employers start offering telemedicine, as Shira mentioned, you're providing medical care, meaning this starts to become part of your group health plans that you're offering to your employees typically. Some telemedicine, I can say, may offer something that would be a little bit less than your usual medical care. It may be something along the lines of your employee assistance programs. But in the trends that we're seeing, that doesn't bring out the truest value of the telemedicine program and being able to deliver that flexible, available care that employers and employees are looking for. So there are many different types of compliance obligations that may arise depending on how you are structuring your telemedicine programs. First and foremost, these plans typically, as group health plans, are going to be subject to ERISA, COBRA, your special enrollment rights, and you need to think about carefully integrating these with your other health and welfare benefit programs. If it's offered as a standalone program, you're going to have those separate compliance obligations that are going to apply to the telemedicine portion itself. Whereas if you integrate it with other portions of your healthcare offerings, such as your major medical, your WRAP plan, you're able to integrate also your ERISA compliance, such as your Form 5500 reporting, your disclosures and communications. So being able to find a way to build them in together can simplify some of the administrative burdens that may arise by offering an additional medical program. Now, in addition to the benefits of telemedicine, a lot of employers offer incentives, whether it's the provider that is able to provide a better price point, or it's the employer that's incentivizing the use of telemedicine. Much of this care is provided at a lower cost to employees, which is great for getting them in the door. It's great for reducing costs on the health plan side. However, the most important thing to pay attention to is that when employers are offering high deductible health plans, it's important to make sure that offering telemedicine at a reduced or incentivized cost isn't going to cause your employees to lose HSA eligibility. This is because when you have telemedicine, which is an incentivized medical plan, this could be considered by the IRS to be additional medical coverage in addition to what individuals would be receiving under a high deductible health plan. However, there really isn't any current IRS guidance regarding telemedicine. It is such a newer feature in group health plans that the IRS still hasn't caught up with regulatory or other guidance. However, the conservative approach would be to ensure that HSA-eligible individuals are charged a fair market value for the cost of the telemedicine, at least until the point that they've reached their minimum high deductible. Or if it's also possible to have coordination between the telemedicine and your health insurance program, if it's only limited to preventive care, being able to kind of fit that in to any kind of benefits that would be accepted from that high deductible HSA eligibility issue. Be aware that there are different types of financing that are available. Either you have a fee for service, which is easier to do a fair market value. It's significantly more difficult if you have kind of an annual premium where individuals can go in and have unlimited visits, virtual visits. So that's also something to keep in mind as well when you're working with your high deductible plans. Coordinating telemedicine cost sharing is also something that employers may want to keep in mind, especially if the telemedicine vendor isn't necessarily coordinating with your TPA or your insurance carrier. The goal is to make sure that when the individual goes out to this health plan, that they're able to apply their cost sharing, their co-pays, their expenses towards the deductible towards their medical plan when possible. And also that helps incentivize employees to go to this program as well. Other things to be mindful of as well when offering telemedicine is HIPAA privacy and security obligations, both on the provider side, because the providers are subject to HIPAA for the care that they're providing, but also on the health plan side, because you are facilitating the ability to go out and receive care, but also have reimbursements for that care. When you're looking at your health plan, the telemedicine provider is going to be a business associate, especially if you have the telemedicine integrated with your major medical. Now, either it's going to be a business associate directly from you, the employer sponsor, working directly with the telemedicine provider, or if it's your third-party administrator or carrier, they would be a subcontractor business associate. Regardless of how this is structured, it's just important to remember that there are HIPAA privacy and security obligations that will follow down the line, and any kind of data that the employer receives as plan sponsor is going to be protected under HIPAA and is going to be subject to certain uses and disclosure rules and requirements to protect the confidentiality of that information. It's also important to, as you're looking through all of the different criteria for the telemedicine providers, to make sure that they are also cognizant and providing solutions on the HIPAA security rules, which goes to electronic protected health information. This goes directly to the point that when you're doing telemedicine and you're able to have web-based or other types of electronic communications, that information is considered to be electronic protected health information, and there are additional requirements for the data security thereon. Other non-discrimination considerations that employer sponsors should be taking up into account is non-discrimination testing under 105H. So if an employer is not offering telemedicine to the entire employee population that is covered by the medical plan, making sure that the offering isn't discriminating in any way that in favor of highly compensated employees. So trying to treat similarly situated employees in the same manner. And finally, as Shira had mentioned earlier, state licensing. In order to ensure that your employees can have eligible medical expenses reimbursed and covered, one of the aspects of that is also making sure that it is the provider is licensed under state law so that they are able to provide that care to you. But as you can see, with the incredible individualization and tailoring that can be done with these programs, there can be a variety of different legal aspects that need to be looked into when you are establishing and maintaining telemedicine programs. Turning now to wellness programs, this is another area in the health and welfare field that has been seeing a significant amount of growth, amount of change, amount of new trends and developments, which quite frankly are quite exciting. Over the past decade, wellness programs globally have actually been growing. They actually represent a $48 billion industry, $8 billion of which is in the United States alone for employer-sponsored wellness programs, which is really and truly a significant market. The Kaiser Family Foundation, in their 2018 Employer Health Benefits Survey, said that actually 82% of large employers and 53% of small employers are offering some form or format of wellness program. So again, this is a long-term trend, but it has been growing in significance and prevalence in the past few years. With this growth come incredible new types of programs. In the past, we've seen more on the side of physical health, nutrition, disease management, so that whole focus on engaging in healthy lifestyles and reducing health risks. This has actually been added onto in other ways as well with the mental health and especially emotional well-being. Some of the recent trends include your employee assistance programs, but also a new focus on self-care, resiliency, and preventing burnout. And preventing burnout is a trend that has actually been more and more prevalent since at the beginning of this year, the World Health Organization has designated burnout as a medical condition, and it is recognized by the ICD-11 as a medical condition. And burnout, as employers know, can significantly reduce employees' efficiency and employees' happiness with the workforce. So wellness programs are definitely looking at these trends as well. Also financial wellness, retirement savings, college planning. When you're stressed about finances, that can carry over into other aspects of your lives as well. And finally, on-site clinics and telemedicine can also be part of that wellness program. Different ways of touching points with employees in meaningful parts of their lives. Now, the industry continues to assess return on investment, and the return on investment studies some have been very favorable as far as the ability to effectively reduce costs. Others have been less favorable. One of the most recent studies came out in April from the Journal of the American Medical Association that analyzed a workplace wellness program that's about 33,000 employees across the country. And the results of the studies are very consistent with other studies. The short-term return on investment for wellness programs tends to be on the lower side. The reduction in costs, they may not be there initially. However, the medium to long-term cost reductions come into play because of the changes in self-reported health behaviors. It takes time to be able to change behavior. Short-term health changes in behavior may not lead to long-term changes, whereas if you have a long-term development of better and healthier workforce, you're going to see that return on investment in the long term. But the value on investment, the communication, the messaging that's being provided to employees about the fact that the employer is looking towards their employees' wellness on a global scale, not just on productivity, but making sure that they feel that they're in an environment that inspires them, that cares for them, that is mindful about the culture. There is an increased value that is being recognized, even though it may not be seen in the immediate term as far as actual cost reductions. Now, wellness programs, this is actually quite a long list of different requirements and compliance issues that employers need to be mindful of. We're not going to go into these in great depth. This could take an entire afternoon. But as you can imagine, the wider variety of benefits that you can offer, the wider variety of different compliance topics that need to be thought through when you're designing, implementing, and maintaining these programs. First of all, the Internal Revenue Code has different tax treatments of rewards. If it's cash, if it's gym memberships, if it is different types of physical rewards like gift cards, those are typically taxable compensation to the employee. Whereas if employers are providing different types of incentives towards medical insurance costs, such as reduced premiums or contributions towards an FSA or an HSA, those are not taxable to the employee under Code Section 105 and 106 as employer-sponsored coverage. So just working through the tax implications as you're designing it will prevent surprises later on. Part of the majority of the wellness program regulations are under HIPAA and the ADA regulations, and they provide the main framework when you think about the design requirements on wellness programs. The regulatory goal for all of these is that the wellness programs are voluntary, they're not using health factors to discriminate, and that really and truly they are designed to promote health or prevent disease. Now, the HIPAA wellness regulations were a product of the Affordable Care Act and issued in 2014. As part of this, the EEOC had also issued regulations in 2016 focused on the voluntary aspect of wellness programs and had issued a different and lower cost threshold, incentive threshold than the HIPAA regulations. As part of this, there was the AARP versus the EEOC lawsuit, and the court had actually held that the EEOC regulations did not adequately justify the lower limitation on incentives, capping it at 30% of the employee's cost for the health insurance option that they're in. So those limitations were vacated, and the EEOC was instructed to issue new regulations to better explain and justify. Now, the EEOC regulations are still in effect, it's just those incentive portions are removed at the moment. Now, they have proposed to have new regulations in effect by 2021. Just an update, the EEOC Commission finally just this last month has a quorum so that they have the ability to act on new regulations. So we are hoping that there will be notices of proposed rulemaking at some point in time this year. The quorum, however, may not exist by the end of the year. We have one of the commissioners whose term is up. So they would be back to 2 out of 5 commissioners, 3 out of 5 commissioners as a quorum. So whether or not they're going to have enough time this year to issue notices of proposed rulemaking, it's yet to be seen, but something to keep an eye on. The next couple slides we've included for your own reference, but it's just a comparison of how the HIPAA regulations and the EEOC regulations are very similar to each other with the very similar goals, but they have different focuses. They have different areas where they diverge. The EEOC regulations are very concerned about making sure that wellness programs are not being used to require participation and are not being used as a way for employers to be collecting information about employees with disabilities. Whereas the HIPAA regulations provide our limitations for different types of incentives. When you have anything that's health contingent, whether it's providing health information or you're requiring individuals to satisfy certain healthcare or biometric standards, the limitations are at 30% of the coverage option in which the employee participates, or if it's a tobacco cessation, 50%. The whole goal as well for the HIPAA regulations is that the programs really need to be provided to similarly situated individuals, and if participation in these programs would be hazardous or injurious to the individual's health, to be able to provide them a reasonable alternative standard. Note that there are notice requirements under both slightly different. HIPAA requires the notice about contact questions, reasonable alternative standards, whereas EEOC is more focused on what type of information is being collected and what is being done to protect it. Please note that there are also the regulations under GINA for the genetic information and family health history general rule. You can't provide an incentive for a health risk assessment unless it's available to everybody regardless of whether or not they answer questions about family health history. Be mindful of ERISA regulations as well as HIPAA privacy and security as well. So
The next topic is association health plans. And strangely enough, association health plans are one of the more exciting topics in the health and welfare space right now. There's a lot of press about them, a lot of movement. Last year, the Department of Labor published some final rules which expanded the use of association health plans, or AHPs. And, excuse me, it's been very, very controversial. There are some states and some people who really, really like AHPs because they see them as a vehicle for small employers to be able to band together to buy coverage on a large group market, which is much more cost effective for them. And those plans don't have to replicate the requirements for small group plans or for the individual market plans. So a lot of small employers really like these kinds of rules. And the thing is that the DOL and under Trump is really trying to expand employer and employee access to more affordable, high-quality coverage, quote unquote. The problem is that AHPs are multiple employer welfare arrangements, or MIWAs to us. And they're not a panacea for being able to go out and jump onto a big health plan just because you want to. They're hard to do. That's because MIWAs are subject to a lot of regulation, not only federal regulation, but also state regulation. There's a lot more state regulation on these plans, especially if they're self-insured, than you might imagine. Thank you. So what happened with these new regulations that came out? Well, we've always had association health plans for a very long time. But prior to these new regulations, association health plans had to be associations where employers banded together, more than one employer, different employer groups could band together. But the sole purpose of banding together could not be just to provide health coverage or to obtain health coverage for your employees. There has to be some sort of, working together, some sort of nexus for these groups. Well, the new final regulations expanded that test to say, okay, you can be an association that allows you to jump into the large plan market if you are employers in the same trade, industry, line of business, or profession, or you have a principal place of business in the same region that doesn't exceed the boundaries of a single state or a metropolitan area if it spans states. I think of like Kansas City. And the problem with this for some people, those who are not really supporters of the AHPs, is because they feel like this is a way for employers to circumvent the ACA's rules on coverage. They worry that these kinds of plans will siphon off the young, healthy people from the individual and small group market, sort of doom them or make them more difficult to be profitable and put them into the large group market. And they especially dislike the fact that you can also include working owners, not just employees, but just working owners in these kinds of plans. Again, it's still very difficult to be a MIWA, especially if you're a self-insured MIWA. States, this goes back to the 80s when there were promoters out there, and not all promoters, but some promoters would set up these AHPs, the Association Health Plans, that were not funded very well. They didn't have very good reserves. Participants didn't get the benefits that they paid for. Sometimes the promoters would take the premiums and run, which is certainly not a good thing. And so the states are given a lot of discretion to govern and regulate, especially self-insured MIWAs. And they actually treat the self-insured MIWAs often just like an insurance company. There you have to have reserves, you have to have disclosures. There's a lot of requirements. And in fact, in some states, it's almost impossible to set up a self-insured MIWA. For example, California. I'm from Seattle, Washington State. Very, very difficult. So that leaves you with the insured plans. And obviously, when you are in an insured environment, you have to be able to find an insurance company that is going to, A, be willing to insure multiple employer welfare arrangement, and also have coverage available in the various states where you have your employees. So there are a lot of impediments to MIWAs. I think that I read that there were 30 new MIWAs set up based on these new association health plans. And if you think about the whole United States, that's not a huge number. Well, the opponents to AHPs have had some success lately. In March of this year, a district court, in a case that was brought by 11 states in the District of Columbia, held that the Department of Labor actually exceeded its statutory authority when it changed the definition of association and employer. And they say this is ridiculous. This interpretation of the rules is not based at all under ERISA and existing law. And we're going to remand it back to the Department of Labor so that you can figure out, DOL, how you're going to deal with this and make it work. Well, the Trump administration did not like that at all, as can be expected. And the Department of Labor very shortly thereafter filed a notice of appeal and also issued some FAQs for those, specifically for those employers and plans that had jumped into this association health plan market. And they said, listen, we understand that there's this case out here. We are going to appeal. And in the meantime, for the rest of the plan year, rest of the coverage period that you are in, you can continue to be in your association health plan if you're in one. You cannot attract or market to new employers, but employers, those that are in this market, you can continue to be in it for the rest of the year, and you can add new employees as you get them. So this is a very fluid situation right now. We'll see. I know that there were some MIWAs that were started in Minnesota, and well, I guess we'll have to see. But I mean, really, this was a very, contentious topic right now. So I'm going to move it on back to Holly.
Thank you. As you can see, all of the different trends and developments involve a lot of highly specialized tailoring, which is what we're seeing more and more of. And another way in which there's tailoring, in addition to your telemedicine, your wellness, your association health plans, you have the selection of top physicians or centers of excellence, where employer plans, it's usually in the larger self-insured space, are able to more carefully curate their networks, selecting providers that are top performing. They're identified as centers or physicians that have high concentration of expertise. They have high quality procedures, demonstrated outcomes, and cost-effective pricing. With the whole goal being is that you're reducing unnecessary care and you're improving outcomes for your employees. It means lower cost. It means your employees are back to being healthy and productive and members of your organizations. There are many different names for this. In the past, it's been called centers of excellence. It can also take the form of tiered networks where you have preferred providers in your network. It can also take the form of narrow networks or even direct contracting. But the idea is that there are certain medical fields with such high levels of specialization, it makes sense to work with those centers that have all of their physicians and services kind of in one package. So in addition to those listed here, you can also think of others such as gastroenterology, neurosurgery, ENTs, individuals with high levels of specialization, and you have developed teams that are able to provide all of the care in kind of a bundled service. From the point in time where you have an individual coordinating your care all the way through follow-up. Most of these are designed as being kind of a lower cost as well. Costs are able to be negotiated in advance so that the pricing is lower based on the cost effectiveness of the product. The way in which this is usually structured is that there is a more generous cost sharing involved. So how do you incentivize individuals to go to these different centers of excellence? Well, you make it less expensive. There is, instead of an 80%, 20% cost sharing, instead of the individual paying 20% out of pocket at the end, they'd only pay 10% in cost sharing. Sometimes co-pays are waived, sometimes it's completely covered. There are times as well that these centers of excellence may be in other cities, they may even be in other states. And sometimes these programs are designed so that travel costs, not only lodging, but transportation, are covered. They may or may not be deductible or excludable from income as a medical expense under 213D. That would require analysis depending on the program that you're looking at. But the idea is that by those cost savings, you're able to offer more by way of taking care of the costs for your employees. There are several practical considerations when designing these types of centers of excellence programs. The first one is that, it necessitates coordination with your claims administrator, making sure that your stop-loss carrier is on board with the type of pricing arrangements that have been negotiated. But also, more importantly, your claims administrator and stop-loss carriers need to be able to work with the bundled codes from the centers of excellence. This is because it's not just the codes coming from the doctor providing the surgery, but it's also bundled with the anesthesiologist, with the hospitalist that's following the care, with the pharmacy care, from soup to nuts. The whole idea is that it's one bundled product. The next is that certain medical fields and procedures are easier to quantitatively compare than others. This is one of the challenges of the centers of excellence and kind of the narrower networks. First of all, it's harder to compare somebody that does absolutely fabulous knee surgeries with somebody who provides your primary care physicians. It's different kinds of skills, but also when you have personal relationships, if employees have personal relationships with their primary care provider, their physicians that they've been going to for years, it's a bit more difficult to be able to demonstrate to employees the value in the reduced costs versus not being able to go to the provider they like. So it's a trade-off. As well, and I think one of the most important things as well when offering these programs is kind of monitoring the results, looking at the centers of excellence, making sure that the cost savings that have been programmed and planned are meeting your goals. But this is definitely a developing and continuing trend. The Wall Street Journal article from April of this year indicated that very large employers such as Walmart are very heavily focusing on centers of excellence. So this is an area that isn't going to go away. And another new and highly tailored trend that we're seeing in welfare benefits is the on-demand health insurance. And this is a type of product that's new for self-insured plans, which allows participants to actually tailor the health care coverage that they are being offered. The whole idea is that there would be a simplified process. The employer-sponsored plan would be structured to have core benefits at a lower and kind of simplified rate. So you'd have your core preventive care, hospital urgent care, and that would be your base core premium. Then for specific types of care, individuals can buy up coverage. So say, for example, there's arthritis that runs in the family and there are 2 knee replacements that are being scheduled. Individuals could buy up the coverage in order to cover those costs of that type of surgery. There are different ways of structuring this. Cost-sharing structures can be generous because, for the core benefits, you can have lower deductibles, smaller or no copays, and then the copays and cost-sharing would depend on the different buy-up coverage that would be provided. So again, very highly tailored. Since this is a very new field, vendors and employers alike are working on different ways of addressing things such as plan administration rules, addressing potential non-discrimination issues related to buy-up coverage. One of the questions that's been raised is that older employees or employees with certain medical conditions may have to buy up more coverage than others. Vendors and plan sponsors have been looking at ways, however, to address these, including the fact that the buy-up is available to all at the same price. So this is, again, a very new trend, but something to keep an eye on. And again, it's not insurance per se, but there is self-insured products available.
I already did that one. So prescription drug spending is, as you can imagine, one of the bigger financial items that employers are facing, and basically the whole United States. The Trump administration, as well as Democrats and Republicans, have really focused on this as something for them to really be responding to. So, for example, in May, the HHS announced a final rule from CMS that will require drug makers to disclose the list price of prescription drugs and TV ads. Now, I don't know exactly, like, it's going to be this big or if it's going to be like this big when, you know, they have all this stuff that's scrolling past you that you can't read. But at least they're trying to address this. There's also, there was a lawsuit that was filed. 44 states have sued some generic drug companies for allegedly conspiring to inflate prices, reduce competition, and restrain trade on some generic drugs. So you can see the states are getting involved, the feds are involved. This is a big ticket item. And Kaiser Family Foundation, I have a couple of slides here just showing, you know, the total number of dollars back in 2017. I'm sure it's larger now. $333 billion spent on U.S. retail prescription drug spending. That's a lot. This shows the percentage of total personal health care spending based on retail prescription drugs back in 2017. Again, 15%, 13%, 6%, big numbers. We're kind of running out of time, so I'm just going to go over some of the final regulations and proposed bills that have come into play recently, just so that you can see these are in the Medicare, Medicaid space. Part D plans now, starting in 2021, I believe, are going to have to provide clinicians with tools to be able to show their patients how much their out-of-pocket costs for prescription drugs are going to be. So the whole point, for example, is we just need to tell seniors what is out there. What is this going to cost you when you're going to buy the drug, so that you don't have a surprise, as Tim and his panel were talking about. And also give them information about what other options are out there. Because some of these drugs are very expensive, and perhaps there is another route that you could take on prescription drug spending that would be less expensive. I'm going to go to the federal anti-kickback statute. This has to do with rebates that PBMs are going to or have been receiving. I think that the concept is that a lot of people thought that there was a negative incentive for PBMs to reduce costs for plan sponsors and for participants, because they had an incentive to have a bigger, potentially, price be paid, because they were going to be getting a cut out of that. So there are now proposed rules by HHS, which says, you know, there's some safe harbors to this anti-kickback rule, that if you actually reflect the reduction in price at the point of sale to the participant when they're picking up their drugs, and also that remunerations for PBMs have to be based on a flat fee service with some requirements. Here's for you, you can look at this, what employers are doing to alleviate drug spending. I will bet that all of you are doing many of these things. And the last slide, we could not let you go without talking about what's going to happen to the ACA. I guess I can't tell you. I don't know. I wish I did. Supposedly, in Texas at least, there was a court that said that the ACA was unenforceable or invalid because it was upheld by virtue of the fact that the individual penalty was a taxing activity that was permitted under the Commerce Clause of the Constitution. And now that there's no individual mandate, then the whole thing falls apart. Well, there's now obviously an appeal to the Fifth Circuit. Trump has weighed in for complete repeal and replace. But there are various rules out there that are trying to strengthen it and or get rid of it in the interim. So we probably have about a minute for questions, but we will also be here afterwards and can talk to you then. So thank you very much.